So good morning, everyone. Thank you. Welcome to the Department of Orthopaedics and Sports Medicine Grand Rounds for this month. Our fearless leader, Dr. Chansky, couldn't make it this morning, so he sends his condolences. Our refreshment cart hit a little snag, so apparently I'm being told it's here. So they're setting up now? They're set up. Okay, so we'll take a play out of Dr. Chansky's playbook. I'll give the kudos, and then we'll save the introduction of our guest speaker until we've all had a minute to get our refreshments. Dr. Bedi has assured me that we'll have plenty of time, so I don't think we need to rush, but we'll kind of quickly do refreshments after the kudos. We have just one kudos this month. It's actually for multiple residents, Doctors Jackie Donahoe, Casey Peak, Greg Walker, and Aditya Yara Pragada. It's from the Emergency Medicine Residency Leadership Team, and it's to alert us that all four of those residents were nominated for the HMC Emergency Department Outstanding Consultant Award. That's an award apparently that was created by the Emergency Department, and honors the consultants who do a good job when they come down to see patients in the ED. I don't know if the award has actually been given, or it has. Okay, so we didn't win it, but we did. Jackie won it. Okay, so that wasn't on my thing. So congratulations, Jackie, for winning it. Congratulations to the rest of the crew for being nominated. That's the kudos for this month. Like I said, we'll hold the introduction of Dr. Bedi until, why don't we just, I guess we'll all just duck out. Let's take 5. Aaron is telling me we have only 5 minutes. So we'll take 5 minutes, everybody get their coffee, and then we'll reconvene. All right. So let's try this again, now that everybody has their coffee and is hopefully getting appropriately caffeinated. So everybody's in? Everybody's here? All right. So welcome again to Grand Rounds for the Department of Orthopaedics and Sports Medicine. This is one of my favorite Grand Rounds because this is the month, at least this year, this is the month that we get to kind of marry our Grand Rounds and our Gehring lecture with our guest lecturer. So for those of you who don't know, we have the James G. Gehring Lecture, which is an endowed lectureship here at the University of Washington for sports medicine, and we always have an esteemed lecturer come give us a nice talk. We have dinner. It's always a fabulous time and with education and things, and so it's wonderful. And this year, we're so fortunate and have the pleasure of having Dr. Asheesh Bedi here from the University of Michigan. You can kind of read his credentials here, but he's the Gehring professor at the University of Michigan. He's the chief of sports medicine there at a very young age, and the head team physician for not only Michigan athletics, but also team physician for the Detroit Lions, and I think does consulting work with the NBA. So he's basically in every sport that matters in my book. And two things to kind of highlight there. So first of all, if you're taking care of college football and you also take care of pro football, your weekends are totally, dominated by football. I can't even imagine how Asheesh does it, but that's the kind of guy he is. If you look at his CV, I think he's just north of 200 publications, peer-reviewed publications. And I think, honestly, Asheesh and I, we might be the same age. He might be younger than me. I think he graduated college 2 years sooner than most people would. And so Asheesh and my paths crossed in some way in the sense that we both did the same fellowship. He was an HSS fellow after doing his residency at the University of Michigan, and then went back there, obviously, to be faculty. But he was a fellow a couple years before me, but it was clear, he made every fellow after him pretty much look terrible because he was, a powerhouse of publications while he was a fellow and just an incredible guy overall. He's very, very modest about his achievements, even though he's garnered a lot of success in his career. He's just a very level-headed guy, so we're really pleased to have him. Obviously, one other thing, Dr. Kwan, my partner and colleague and our faculty here, as you all know, he did his fellowship with Dr. Bedi at the University of Michigan, so that's how kind of this whole thing has come full circle. So we're extremely pleased to have Dr. Bedi here. He's going to talk to us about slap lesions and the biceps tendon, which obviously, for me, is an incredibly interesting topic. So please help me in welcoming Dr. Bedi.
Thank you. Well, thanks very much, Al, for that all too kind introduction. As you can probably tell, maybe I think I'm chronologically younger, but I think I'm about 20 years physiologically older than Al, as demonstrated by my alopecia and the rest. But this is honest truth. To me, one of the most enjoyable parts of this profession, and certainly being in academic sports medicine, are the unique touches that you get, and hopefully for the residents and the fellows and certainly the faculty I know in the room. It is a real honor to do that, because you learn from many of the mentors above you, and then you have the pleasure of seeing those that you've either trained or had the opportunity to train with go to their respective areas in the world and really train others and start their own career and path to contribute to the field. And certainly Al and Chris have been no exception to that, and from spending a little time with the residents and last night, but also at all the different places that you interact with them, certainly it's clear that they are a huge pillar and part of your program. For me, to come to the University of Washington, a storied program with people like Rick Mattson and Doug Hanel, who I know is in the back, who are legendary in their fields. I hope that the trainees don't take that for granted, because I didn't have the pleasure of training with them, but certainly am envious of those who did and try to learn from them at meetings. For me, as you know, Al and Chris are two touch points for sports medicine. Al followed me at special surgery, but maybe just as he heard a little bit about me as the dorky Indian guy who wrote a lot of papers, I maybe heard about him as a clinical talent that everybody loved, and certainly has gone on to, in very short order, be a major contributor here. And I was so excited to see Chris, one of our graduates from the university, be an ambassador in sports medicine in an academic program at the University of Washington. You have a number of fellows as you get older in years, but you certainly enjoy to see the fellows who go and pursue things like you have. So thanks so much for the opportunity to be here. I don't have any disclosures related to this talk. I am a consultant for Arthrex, but certainly don't have any conflicts in the content of this presentation. And I was told a little bit when you're giving these talks, particularly a grand round talk early in the morning, I sort of want to have maybe just one or two take-home points, because I think if you have 1,000, you usually lose your audience. And for me, I think the take-home point of slap tears and biceps procedures is really kind of interesting as a surgeon, because I would advocate that the vast majority of the time the treatment for these is actually not surgery. And if you actually refine and look at your indications for treating superior labral tears, you'll start to realize that these can be over-treated in a hurry. And so maybe a central theme here is to realize that the process that you go through in the clinic before you get to the operating room is of paramount importance to actually what you might do in the OR. So in terms of talking about slap tears, what is it? I think everybody in the room, but certainly for the trainees, know that this is primarily a pathology of the overhead athlete, not the average population. So when you get MRIs and MR arthrograms that have now become the norm rather than the exception, these are often findings and reads from your radiology colleagues or on your own. But be careful to label them as pathologic findings to warrant an operation. We know there's a great discrepancy even in the radiographic agreement. If you take a number of surgeons and sit them in the room to classify tears, J.P. Warner did a paper that showed we all can't even agree on what a type 2 tear is. And then we know that our physical exam findings from Ed McFarland's papers and others are highly sensitive and largely nonspecific. As you guys are in the clinic with Dr. G or with Dr. Kwan, or I know your shoulder and elbow group with Dr. Mattson and Shu and colleagues, I think you realize that many patients have positive O'Brien signs and speed signs and Jurgensen tests, and that can mean a lot of different things. It doesn't necessarily mean a slap tear. Make sure that you recognize if there is in fact what you believe is a pathologic slap tear, that in fact you understand why it formed. We recognize now more and more that the slap tear is in some ways the smoke, and the underlying fire was the pathologic mechanics that led to that tear. Most commonly, that reflects things like posterior shoulder capsular contracture or glenohumeral internal rotation deficit, scapular dyskinesia. And if you just treat the labral tear with anchors and looped sutures and you leave that underlying pathology, I think you'll be humbled to find that the tear recurs or the pain is still there. So when you classify a slap tear, I put this picture in directly from Steve Snyder's paper that initially described this. We tend to, in orthopedics, describe things anatomically. So here you have this type 1 tear, which is the frayed edge, B, where there's some lifting from the articular margin, C, which is the more classic bucket handle tear, and then this D, which is a type 4, which extends into the biceps anchor. And this helps us in terms of thinking as surgeons how we might treat these, anywhere between repair to excision and repair to a possible biceps tenodesis procedure. And I think that's important that we recognize that anatomy, and then correspondingly, as you can see, it's critically important that you recognize, given that intimate relationship with the biceps, what is the stabilizer of the biceps tendon. We know that laterally it's the coracohumeral ligament and the anterior leading cable of the supraspinatus. Medially, it's the coracohumeral ligament, but also a reinforcement from the superior glenohumeral ligament. And this is that so-called biceps pulley or sling that we sometimes see disrupted in the OR that can contribute not only to an unstable biceps, but to a subscapularis tear as it can scissor and work into the rotator cuff. But this, I would argue as the talk goes on that while we should consider this anatomy, ultimately we need to consider these slap tears in a binary sense. Which ones really need treatment and which ones don't need treatment. So in terms of the anatomy, this is, I'm sure, what you guys are used to seeing in the OR. You can see a stable biceps tendon and sling here. When you do your pull test in the OR with your probe, the one on the left side of the screen stays contained in the groove. The subscapularis tendon is intact. Here on the right side of the screen, you see the tendon can sublux. If you were to do a leave or push test, you might see that there's a tear in the cranial border of the subscapularis tendon. So think about that, because these lesions probably see us more than we sometimes see them if we don't do a dynamic exam. And why is that important? Because we recognize that when there is in fact a so-called pathologic slap tear or a slap biceps lesion, how is this happening? Even to this day, multiple mechanisms have been proposed, none of which have been identified as the clear leading cause. You've heard probably of the peel back mechanism, which is in throwers, where the arm gets into abduction and hyperexternal rotation. That starts to theoretically peel the superior labrum and biceps complex from the posterior-superior glenoid. Craig Morgan and others describe that concept. You've also probably heard of the so-called weed pulling mechanism, where there's traction that directly is on the biceps that then leads to direct force on the labrum. That's more this mechanism here, where inferior force on the long head of the biceps can lead to quote-unquote inferior subluxation and a subsequent traction injury to the labrum. The challenge, of course, is that to this day, none of us totally or truly know how much the long head is a contributor to this mechanism. Ken Yamaguchi and others have published work that in EMG activity, the long head is largely silent during much of clinical work or shoulder mechanics. On the other hand, we know from J.P. Warner's work that when you cut the long head of the biceps tendon, there is some superior migration of the humeral head, such that it is at least a passive stabilizer and dynamic humeral head stabilizer in certain range of motion. As I already emphasized earlier, physical exam is helpful, but you have to be careful about hanging your hat on all of these tests. And certainly I didn't put an exhaustive list here, but you all know the SPEEDS test, so-called active compression or O'Brien's test shown here, an apprehension relocation test if you think there's associated instability. But if you look in the literature, there's certainly at least 20 more tests for slap lesions, so-called Kim's tests, etc. All of those tests are largely, as I mentioned, sensitive, but not largely specific. They have about a 50% positive and negative predictive value, such that these are clues to associate with a possible slap tear, but certainly not pathognomonic. I think this is a take-home point here, which is MRI and MR arthrogram overcall slap tears. So I think you have to be careful about an MR study that says a slap tear and treat a shoulder problem or shoulder pain as an isolated slap lesion. For me, this is quite the opposite. You need to rule out every other potential cause and then end up as the slap lesion in the right patient and population. Why do I say that? These are images that show this here. You can see the so-called sublabral foramen. I think all of you in the OR, and certainly with the great faculty, are educated on this in the clinic. You can see this looks like a quote-unquote tear of the labrum here on these axial images, but this often reflects a cord-like glenohumeral ligament or Buford complex or a sublabral foramen. This, in fact, would be not only not benign to treat, but if you, in fact, close down this sublabral foramen and treated it like a slap tear, this patient would, in fact, have pathologic stiffness, lose external rotation, and functional range of motion. So in these situations, treating a slap tear is not, in fact, benign, but, in fact, can be problematic. This is your so-called type 1 slap tear, which is the frayed superior labrum in the setting of an intact biceps. These are degenerative and probably, to be honest, a normal finding. I think these are sometimes the things that we quote-unquote clean up while we are there, but these are not really, in my opinion, isolated pathologic lesions that are a cause for shoulder pain. This is maybe the most controversial of them, which is the so-called Snyder type 2, where there is a detachment of the superior labrum, but there's undermining that extends below the labrum into and beyond the articular cartilage. The key here is that it's not a so-called meniscoid variant, where in fact you see a normal articular junction, but that you actually see pathologic exposure of bone. These are some of the findings you look for on the MRI. While we often look on the coronal image, as you saw there, here the axial image is most helpful, where you can see this fluid that's extravasating all the way between the labrum and the margin of the glenoid. Here, this would give you some concern that the extension of contrast is pathologic. As some radiologists, including Dr. Potter and others, have published, you have to be careful, however. MR arthrograms exaggerate this finding, and meniscoid variants can look this way. Oftentimes, for this reason, some radiology teams have advocated for non-contrast MRs so we don't overdiagnose these lesions. This is what these can look like in the OR. You can see here the typical pathologic fraying, but here, again, dynamic testing to lift that biceps superior labral complex off of the superior glenoid and to visualize that exposed bone beyond the articular margin. Again, is this a pathologic slap in every case? I would argue no. And as we move beyond just this anatomic portion of the talk, I would argue about treating these more as so-called good and bad slap tears rather than treating these as type 1 through type 4 slaps. This is maybe a little bit more clear type of injury. This is your type 3 slap that we talked about. You can see here where there's not only that lifting off of the labrum from the glenoid margin, but here you can see that bucket handle type of tear, or where here it's extended to the biceps anchor but not into it. That's a different type of lesion where usually that does warrant treatment at minimum to excise that labral fragment, which is a mechanical source of symptoms, and then to decide whether a repair of the remaining labrum versus a biceps tenodesis is an appropriate procedure. So I'm going to switch gears now from that anatomic discussion. I wanted to provide that backdrop because that's how we all think as orthopedists, but maybe step back and tell you why I don't recommend treating slap tears all that commonly. This is the latest literature when you look at slap repairs in throwers. And this is systematic reviews, one done from the Rothman group by Chris Dodson and others. Here, these publications in 2012 and 13. And if you look at the rate of return to play after slap repair in throwers, it's a humbling number. I don't think any of us would like to see 22 to 64% of our athletes get back to sport after our surgical intervention. And I think this harkens back to the primary conclusion, or hopefully take-home message from my talk, which is that slap tears are usually not the problem. A paper by Bryson Lesniak from the University of Pittsburgh showed that when they looked at Major League Baseball pitchers, 48% of their asymptomatic pitchers had a slap tear. That, to me, suggests that slaps are almost endemic in a throwing population as opposed to clearly pathologic. In fact, Tony Miniacci at the Cleveland Clinic published that 80% of asymptomatic mature pitchers had MRI changes consistent with superior labral and biceps pathology. So again, be careful to label this as a pathologic lesion in a throwing population. In fact, it may be obligatory for them to achieve their external rotation and their mechanics. This is a paper in AJSM in 2014 by Federow. If you look here again, these humbling numbers, the reason to treat these surgically, if you are a surgeon who believes in treating all these slap tears, would be the top of the screen. That non-operative treatment doesn't really work well. When Art Rettig and others published on this, they only got 40% of their players back to sport. On the other hand, compare that to the operative group, 48% and 7%. So when you look at the numbers, are we really that incrementally improved over non-operative treatment at all? So I would argue that when you're treating slap tears, and certainly as I've lost more and more hair, the indication for me for a slap tear has in fact become more refined. To me, it has to be the following, which is you've addressed the underlying pathomechanics of glenohumeral internal rotation deficit or scapular dyskinesis, that you have the concordant physical exam and imaging findings with a pathologic slap tear, but you failed non-operative management, and the surgical approach that you use does not in fact adversely affect their glenohumeral mechanics. So if you've met all of those criteria, then it may be reasonable and appropriate to treat the slap lesion. Well, why do we know this? If you look in 2013, what things give us a potentially bad outcome if you treat a slap tear or biceps pathology? If your ASES score starts lower than 50, if you're older than 40 years, if you have another number of coexisting comorbidities, but more importantly, what if there's pain in the bicipital groove? What if there's diffusely positive biceps and superior labral findings on physical exam? Or if your job has high manual labor demands? Studies would suggest that all of those factors would already predispose to a modest outcome after superior labral repair surgery. And this gets into the area about when we may rather treat these patients non-operatively or also treat their associated biceps pathology. So this gets to be a big list, but I think these are the things you need to think about in the operating room when you're with your shoulder surgery faculty and your sports faculty in the OR. When you're looking at in the OR, you need to see and identify synovitis in areas that may suggest occult pathology other than the labrum. You always want to address any potential occult rotator cuff pathology. As we discussed, a number of cranial border subscapularis tendon tears go unrecognized. These need to be addressed and are probably more the source of symptoms than the biceps pathology or labrum itself. If you do believe the biceps is pathologic, you need to do a pull test to distinguish what is intra-articular versus extra-articular and in the groove. And then certainly if it's a revision case where a superior labral repair has been performed, you need to address the potential for contracture, knot stacks and associated fibrosis, or iatrogenic injury to the rotator cuff and biceps tendon. So as I mentioned earlier, this is maybe simplistic, but what has been popularized by John Conway, Jim Bradley, Neil Elatrosh, and others, which is rather than think about slap tears as type 1s through 4s, as Steve Snyder initially proposed to us, I think we should think about that more for our anatomic decision-making at the time of surgery. But in terms of a decision-making for surgery, I think we need to think about them as so-called good and bad slaps. What do I mean by that? I think the good slap tear is in fact the one that is obligatory for a thrower. It's purposeful and beneficial. It allows greater labral mobility for them to achieve the external rotation and velocity for their performance. But you need to distinguish that from the pathologic or bad slap, in which there's abnormal translation and microinstability of the shoulder that leads to loss of velocity, loss of control, and poor performance. So it may in fact be that we need to ignore or gently debride the good slap tear, but fix the bad slap tear. When do we see this? We certainly see this in our population, and I know the University of Washington would have elite athletes and no exception. This is a patient that I've seen, for example, who's a 20-year-old University of Michigan college pitcher. Here you can see he's had this prior slap repair at his first surgery, performed here with what looks like technically appropriate work. The anchors were placed behind the biceps anchor. The biceps was not incarcerated. The sublabral foramen was not closed. But when you look back, the patient never returns to sport, continues to have pain and weakness. When you look at the time of the second surgery, this is actually a successful surgery from a healed superior labral repair, but in fact a failed operation for the patient. Wasn't able to return to sport, has abrasion and synovitis related to this repair. So did we in fact do something that wasn't favorable for the athlete? So for me, the steps in doing this surgery is to identify and treat all of the associated pathology first. Here you can see in this patient there is in fact associated anterior instability and an anteroinferior labral lesion. To me, the microinstability of the shoulder is in fact the pathologic problem in this patient. It's key to stabilize that and to restore the tension in the anterior band of the inferior glenohumeral ligament. It's my preference to use knotless anchors to avoid knot stacks and abrasion. And once that's been treated, we've addressed the associated pathology. We can then treat the labral tear, but not treat that as the isolated superior labral concern. These are all the things that you should be looking for in the OR. As I mentioned, when you're treating the biceps, look for what's in the groove, but not just what's in the joint. You need to pull that into the joint and assess that. You need to assess the subscapularis and supraspinatus tendon. You also need to address the infraspinatus if there's associated internal impingement or injury to the rotator cuff cable. All of those will be larger contributory pathology than the superior labral tear itself. Well, as we work our way through that and assume that now the biceps is part of this pathologic contributor to pain, what could be all of the different contributors? Well, certainly we know groove pain with a normal tendon exists. Could it be a so-called hourglass deformity, which has been described by Pascal Bouleau, where the tendon is in fact had hypertrophic enlarging and in fact cannot slide in the groove? Does this necessitate more of an open tenodesis procedure? Or these anatomic variants, in this case shown on the bottom of the screen, where there's a bifurcate long head that's actually taking origin to a degree from the undersurface of the confluence of the rotator cuff. And as all of you know from working with the various surgeons at the University of Washington, my guess is that if you ask them how they do a biceps tenodesis procedure, you might get 10 different answers. And that's because there are at least 20 different ways to do this operation, none of which has been described to be the right or wrong. And these are the considerations that go into it, not only with regard to which fixation technique or device they may use, but where you place it. Is the top of the groove appropriate? If you believe the groove is a contributor to pathology with pathologic vincula or an hourglass tendon, does it need to be done at the base of the groove but suprapectoral? Or should this be done subpec to eliminate all potential pathology? Well, if you look at the results and data, this is a recent paper from the BRASS group, which is Steve Burkhart's group and his colleagues and former fellows. They looked at over 1,000 cases of a proximal biceps tenodesis procedure for so-called biceps-related pathology, and they reported a very high rate of success with less than 4% rate of complications. When you break down the BRASS study, this is what they found. The vast majority of who they're treating are patients who had biceps instability with a subluxing tendon, usually in the setting of an associated cranial border subscapularis tear. Probably a very appropriate indication for a tenodesis procedure. I would draw your attention, though, that in terms of biceps tears and tendinopathy, that was the remaining percent, and the vast minority of the cases were, in fact, for the slap tears. So while we sometimes say treat these slap lesions with a biceps tenodesis, note that even in the hands of our high-volume providers, these are mostly being done for primary biceps pathology, not your slap tear. So tenodesis for slap, when might you consider it? Well, Pascal Beaulieu has published this paper that I think is frequently quoted in operating rooms, which is when the patient was over the age of 40, a primary tenodesis procedure seemed to have more favorable outcomes than a primary slap repair compared to patients under the age of 40. I would draw your attention to this paper. While it's a valuable contribution to our literature, I would note it's not a randomized control trial. It is simply a case series and suggests that we should factor age into our decision making. Again, workers' compensation patients we know are also contributory to all of our outcomes in orthopedics, and certainly Doug Handel and others have published on this in the hand surgery literature. Slap tear outcomes are worse in workers' comp patients over 40, where patient motivation and secondary gain can be an issue. So as I mentioned, when you're performing a biceps tenodesis, what's the right way? Do you do it at the top of the groove? Do you do it with an anchor? Do you do it with one of these button devices? Do you need to tenodese the tendon to bone, or is simply anchoring to the surface enough? The honest answer is probably none of these factors matter that much, and all of these are probably more surgeon-related factors that are of interest to us technically. The reality is probably that if you're going to perform the procedure, that you restore the normal anatomic length-tension relationship. Pat Denard and others published on this. It turns out that if you look at the distance from the biceps root at the top of the labrum to the groove, it's about 25 millimeters. So when you detach your biceps at the time of OR with your surgeons and perform a tenotomy, that tells you that you really have about 23 millimeters of tendon left if you choose to put it into bone. And so in that regard, you're really not going to trim too much tendon if you put that at the top of the bicipital groove. On the other hand, if you choose to do a subpectoral approach, you need to remove and trim tendon to the level of the muscle-tendon junction. The key here is more about restoring the length-tension relationship of the biceps wherever you choose to attach it to the bone, not worry about which fixation device you use. This is one of my preferred techniques here. Doesn't much matter which technique you use, but in this case, this is an arthroscopic approach where we're actually preparing a little bit of a socket in the bone. Doesn't look like that's playing here, but in any case, we prepare a socket in the bone. We ream that down to about that 20 millimeter number and then allow us to dock the tendon into bone there. Again, the key point I would argue here, though, is that in addition to treating the biceps tendon, it's critically important that you actually treat the associated pathology. So here, when you look more carefully, you appreciate that in addition to a subluxing biceps tendon, there's in fact a leading edge tear of the rotator cuff cable. So where do we need to also be careful about over-treating these lesions? And as I think I told you, my take-home point for this talk was to not over-treat and minimize your treatment of slap tears and biceps pathology, is because every one of these cases can be met with some complications, however rare. If you look at Alex Shin's work here from the Mayo Clinic, he talks about iatrogenic nerve injury during shoulder surgery. And if you look in their talk, they see the following in their manuscript in JBJS. The open procedure for biceps tenodesis was responsible for most nerve injuries at the time of shoulder surgery. The musculocutaneous nerve was lacerated at the time of placing a tenodesis screw in one case, and the median nerve was actually mistaken for the biceps tendon and tenodesed in these other cases. So while these complications can happen rarely, if they do happen, they're devastating. And I'm sure Dr. Handel and your hand surgery faculty here at the university can talk to you about all of the challenges this can create for a patient for a seemingly benign anterior shoulder pain that now can result in tendon transfers and considerable dysfunction for an elite athlete or a throwing athlete that was embarking on a high-level career. What about musculocutaneous nerve entrapment? Be aware that when you do a subpec tenodesis, the musculocutaneous nerve is not far away. This study at the University of Minneapolis and in Chicago pointed out that when you do a dissection subpectorally, particularly if you do an axillary crease-based incision, it's 5 millimeters away, and if you don't place your retractors carefully to retract and stay right on the humerus medially and on the humerus laterally, it's easy to have the musculocutaneous nerve slide into your field and be mistaken for your long head. Well, what else? Sometimes our fixation devices can create challenges. When you do a subpectoral procedure, you don't appreciate it if you're not using fluoro to recognize how low that is. It is entirely cortical bone. When you're reaming at this location and placing a 7 mm tunnel at this location, particularly with bicortical fixation, this is a stress riser. Usually, as you know, with humerus fractures, these don't occur necessarily in compression or axial load, but rather in torsion. And so for our throwers, this can be a pathologic risk or concern. Let's also pay attention to the fact that we know the radial nerve is on the back of the humerus in that location, and the axillary nerve can wrap around. If you do a suprapectoral tenodesis at the base of the groove but above the tendon, the axillary nerve is at risk. And Paul Sethi did this study in JSES that pointed out it was as close as 5 to 7 millimeters with a bicortical pin at that location. So to me, the take-home point here is that which fixation device you use is not important. And I will not advocate for a button over an anchor, over a suture device. The reality is just make sure that whichever device or technique you use does no harm. This is a case report in JSES shown here in a thrower where a bicortical fixation device in a subcortical location, in a subpectoral location, actually resulted in a torsional fracture of the humerus that then results in this subsequent procedure. Certainly a less than optimal outcome. So I would sort of conclude this talk a little bit by saying, what are your goals for a slap tear? If you are addressing labral pathology, you have to make sure that it is the source of your pain. Debridement versus repair is the gold standard, but make sure you address any associated anterior or posterior instability and extension. If you do believe the biceps tendon is part of your pathology, certainly choose to treat it with a tenotomy or tenodesis procedure. Which procedure you use is probably less critical. Restoring the length-tension relationship to treat in a thrower is probably more important. And make sure that you recognize that the slap tear is often the smoke and not the fire, so address your underlying subscapularis tears and supraspinatus tears. So in summary, I would take you to maybe this slide, which is what I've learned in the past 10 or 12 years of practice, which is I only favor a slap repair when you've corrected the underlying pathologic mechanics of the scapula and the glenohumeral joint. You don't have a confounding long head biceps or rotator cuff lesion that is probably the source of pain. When there's treatment of associated pathologic instability for the bad slap tear. But beware that if you do a lot of slap repairs, your expectations of return to play need to be modest, because our literature suggests that a thrower does better without this surgery than with this surgery in most cases. So thanks very much for your time this morning.
I think we have plenty of time for questions.
Hey, thanks. Great talk. What do you think is the role of a tenodesis in a thrower? And then there's a big debate on whether if you do a tenodesis, you should maybe repair the superior labrum at the same time. What's your view on that?
Yeah, it's a really good question, and I'll give you my level 4, level 5 evidence view, because to your point, I don't think we have the answers to those. For me, I do think there is a role for a biceps tenodesis procedure in a thrower. That being said, I think it's much like my last slide alluded to with regard to the slap tears. In general, I think for throwers, performing any anatomically altering surgery puts them at risk, particularly for an elite level athlete. I think a biceps tenodesis procedure, particularly in the setting of groove pain, in the absence of any clear intra-articular findings, for example, some peel back of the superior labrum, but not a true type 3 or type 4 lesion, for me is a cause for concern with a primary repair. I have done this in 3 or 4 University of Michigan pitchers and 2 professional pitchers after an intra-articular injection and a groove injection to confirm full relief of pain. In the absence of any significant imaging findings on the MR arthrogram that suggested the primary labral pathology was the cause of problems. I have not treated the associated labrum. So I have not also repaired the labrum and done a tenodesis. I've simply taken away theoretically the traction on the labrum by treating the biceps, and they have fortunately gone on back to sport. But I'd say probably in 10 years of doing it, it's 4 cases in that population. I think that's different in the failed slap. So in a patient who's had a prior repair, including throwers, and continues to have pathologic shoulder pain, in that situation, I think a primary biceps tenodesis procedure is probably the best operation you have, not a revision slap repair.
Thank you. Quick question. I know you have gymnasts also at Michigan, and that's probably the other group of athletes where we see a lot of shoulder pathology, stability issues, and then also slap issues, variable on MRI. In terms, it sounds like in the thrower population, a lot of caution about this procedure to try to get them back. What about, do you personally, or what do you think about the gymnasts?
Yeah, I think it's a really good question, and actually maybe a question that I would love to learn from Al and Chris and all the faculty a little bit about how do you tension these repairs. So I think in most of these cases, certainly in the throwers, we see the slap lesion, but it really reflects, as we mentioned, either posterior capsular contracture or associated anterior microinstability. And for me, the challenge is if I do believe that there is some component of instability that's contributing to this problem, A, how much am I treating it? And B, in the OR, how am I titrating that repair to restore stability but not, in fact, cause them to lose the external rotation they need for sport? So it's a little easy in maybe the stadium shown here, because in the football population, I tend to tighten them as much as possible because the goal is different. Loss of external rotation in that population is largely well tolerated with the exception of some positions. For pitchers and gymnasts, I think you have to be very careful. So for me, that's one where I'll spend a lot more time not doing the largest pinch tuck in the OR to eliminate a drive-through, but rather to feel that I'm restoring normal balance and tension to the anterior band of the inferior glenohumeral ligament. David Dines and his group has published that sometimes to help do that, they actually perform their tying and repair in an abducted and externally rotated position in the OR, so you can confirm that the patient can achieve that rotation. I think that's one good trick to look at that, or at least to consider it in the OR. But to be very honest, I don't have a great exact intraoperative tool to know how much is enough tension without creating loss of external rotation. So Al, Chris, Joshua, you have some thoughts on how you do that in this population? How do you titrate your retensioning? And when do you add an associated posterior capsular release if you feel that that's contributory in GERD? I've not done a lot of posterior capsular releases, but certainly Craig Morgan and others have published on them.
To address your question about gymnasts, I've had one gymnast who failed a slap repair, and I repaired her slap because she was young and I probably didn't know any better at the time. So she ended up failing, and I ended up doing a tenodesis on her, and she actually got back and competed, but I don't know that she still loves her shoulder. The microinstability question is, I mean, that's what's so challenging about these problems, right? Like we're talking about, it runs the gamut from microinstability of the anterior capsule and inferior glenohumeral ligament complex, where you're doing like a subtle kind of capsulorrhaphy, to doing like posterior capsular releases because we think that they have, glenohumeral internal rotation deficit GERD. So I would just basically, I'm going to answer your question with another question. Is I don't know, and I don't think anybody does. And it's kind of all over the map, which I think is what makes this population so frustrating. I mean, my counsel for a lot of our throwers is that it's almost like I don't talk to them about the slap tear because I feel like that heralds that they may not be able to pitch anymore, regardless of what we do. Right. So we do as you say, and we treat them all as kind of inherent things that these pitchers may have. We try to rehab them as much as possible and almost at all costs not operate on them, and then do very limited work when we go back, if we have to go back in.
I totally agree, and in some ways, with NFL football starting, I think Andrew Luck is a classic example of that, where you have a posterior superior labral tear in a quarterback, which doesn't have quite the demanding mechanics of a pitcher, and even subtle changes in kinematics can make it very difficult to get back to sport. One thing that I've learned, and Chris, maybe you can comment on this, is anytime I see associated changes on the articular side of the infraspinatus at the time of embarking on treating a slap tear, I get pretty worried. I think that's more reminiscent of internal impingement. If you see that partial thickness articular-sided tear in the infra, I think beware, because that's suggestive of an underlying posterior capsular pathology, and the labral tear is sort of what we treat because it's the easiest thing for us to treat with our tools. But I'm not sure that it's always the real problem there. Doc.
You talked a lot about being sure you've adequately rehabbed before considering it. Not being a shoulder surgeon, it's not an exam that I do frequently. What do you use to say you've done adequate rehab? Is the number of visits, how long they did it, specific strength tests?
Yeah, it's a really good question, which is, do we have any metric to really say, have you really failed non-operative treatment? I think everything you just pointed out is very true. The metrics of just commitment to it are very hard. Well, did they do the right number of therapy visits? Were they actually compliant with the process? As we also know, no two therapies are the same, so was the shoulder rehab the right type of rehab? What I've tried to do is a few things. One, I do think for this population, and particularly if you're treating a lot of these kind of athletes, it does make sense to have a therapist who's dedicated primarily to shoulder or throwing athletes, because they'll have a much better understanding and appreciation of the stretches and mechanics that need to go into this. It's a group of sleeper stretches, or so-called throwers 10, which are 10 stretches that the athlete needs to do reliably. I also think, though, there are some quantitative mechanics you can use. So if I do see a patient like this, I will write that day, much like you might send a patient who has an ACL tear for a leg press test to assess where their quad strength is at baseline. I actually do send them for some range of motion baseline numbers. So you can assess where their glenohumeral internal rotation deficit is that day. If they're greater than 20 degrees different in their throwing and non-throwing shoulder, some papers say 17 degrees, but whichever number it is, you can document what you have in terms of their initial lack of internal rotation. There's some semi-quantitative mechanics for tightness of the short rotators and of the short head of the biceps and the pec, which can lead to scapular protraction. So look at essentially some measures that you've made both with a goniometer and with some manual assessment for range of motion, and then hopefully see that those gains have been achieved after 10 to 12 weeks of therapy. If they've restored their normal mechanics in terms of glenohumeral internal rotation deficit, if they don't have scapular dyskinesis on exam or dynamic winging, improved protraction, to me at least that's some metric that you've improved their general kinematics and they've made efforts towards that but still are having pain. It's about as quantitative as we've been able to do it. Unfortunately, a lot of it does, though, as you point out, still depend on relying on the patient's commitment to it. And I would be lying if I told you I don't think there's a school of thought that sometimes the 3 portals and putting in the anchors makes the therapy feel more important for the patient.
Just out of curiosity, what did you end up doing for that patient that you went back on and you showed us the synovitis and the superior labrum?
Took out the sutures and not stacked, debrided the synovium, did a tenodesis.
Did a tenodesis.
Yeah.
And what, in the situation where you do see the partial undersurface rotator cuff tear or the infra, are you doing something to that tear? Are you doing some kind of a partial repair, or are you just debriding it and then going after the capsule in those cases?
If it's more of in that situation, more of a type 1 or 2 where there's some subtle peel back but not significant exposure, I've actually chosen to not repair that. Note the intraoperative finding. If there is in fact full exposure of bone and peel back, I will put some anchors there, but I will really prescribe to the therapist afterwards that the primary mechanics and problem need to be addressed. I'm more aggressive in that population. We tend to be more conservative with instability and not moving those shoulders early. That's a population that I move more quickly.
So good. I think one of the points that you made about people taking their rehab more seriously once they have the 3 poke hole incisions and pictures of something having been done is real, in addition to the, on average 30% improvement that you'll have as a placebo effect from just any treatment that you do. And when I've talked to patients about it, or when I show them the arthroscopic photos, I make a point to say, there was some mild damage because you're an overhead throwing athlete, and we cleaned it up, and that shows how you have to restore these mechanics to, keep this the engine running well to do what you need to do. And I do think that there's some real, it's not, I wish there was a way to do that without the arthroscopic photos and just showing the MRI images, but I think that's like a point not to be understated.
Yeah. I agree. There's a little, I guess, common theme to the 2 talks here. The evening talk is a bit more centered on the hip. And one of the things that I've learned in short time is, in some ways, we've created some of our own challenges in orthopedics and sports medicine where the term tear is a challenging one to deal with a patient. It's hard to see a patient who has a hip MRI and hears the word hip labral tear and leave your office with the perception that you're leaving a pathologic tear unaddressed in a shoulder or hip joint. And so I think that's our challenge here, is that these are slap lesions that are in many cases, anatomic variants or normal senescent process in an aging shoulder. But when they're labeled as a tear, the patient feels much more satisfied that you treated it or removed it than that you actually somehow are convincing them that leaving it in place is the right treatment. And it gets challenging in a healthcare environment where an office to the right or left is happy to treat it.
Any other questions? Oh, Asheesh, thank you again.
Well, thanks
Fabulous
very
talk.
much. Hope that was
Fabulous
okay.
talk.
Thank you.